Hello, everyone, and welcome to today's keynote webinar titled Outsmarting the Escape Artist, Resistance in CAR T Cell Therapy for Hematologic Cancers with live Q&A. This webinar is a part of the second annual Cell and Gene Therapy virtual event series. My name is Sydney Panilla, and I will be your moderator for today's event. Today's web seminar is presented by LabRoots. Before we begin, I would like to remind everyone that this event is interactive. We encourage you to first participate by communicating with other attendees using our live chat feature during the presentation. You can find the live chat located at the left of your screen. You can also participate by submitting as many questions as you would like during the presentation. To do so, simply type them into the Ask a Question box and click Submit. We will answer as many of your questions as we have time for at the end of the presentation. If you happen to have any trouble seeing or hearing the presentation, click on the Help Desk button located at the top of your screen within the navigation bar or from the lobby within the event. Finally, as a reminder, this presentation is educational and offers free continuing education credits. Click on the Continuing Education Credits link located in the Abstract tab from the menu at the left of your screen and follow the process to obtain your credits. Okay, now let's go ahead and get started. I now present today's speaker, Dr. Marco Ruella, Associate Professor of Medicine, Scientific Director, Lymphoma Program, University of Pennsylvania. For a complete biography on our speaker, please visit the Presenter tab from the menu on the left of your screen. Okay, Dr. Ruella, you may now begin your presentation.
Well, thank you, Sydney, and thank you to LabRoots for having me. It's really a pleasure being presenting at this conference as the keynote. So I will be sharing with you some of our latest finding in the field of CAR T-cell immunotherapy, and I will try to discuss topics in the setting of resistance and also some work that we've been doing in toxicity. These are my disclosures that might affect the work I'm presenting. I would like to stress that I started a company called viTToria Biotherapeutics, and some of the data that I will be presenting are generated in collaboration with that company. So it is certainly a great time in immunotherapy for cancer because we have 7 FDA-approved CAR T-cell therapy for liquid cancer. We have a couple of adoptive T-cell therapies also approved for solid cancer, tumor-infiltrating lymphocytes, and TCR-directed T-cell. And so it's an extremely exciting time for in our field because we have so many products available for our patients. And you can see that there are multiple products, some of them, 5 of them against CD19, 2 of them against BCMA with different indications within B-cell malignancies and multiple myeloma. And so being fortunate to join the University of Pennsylvania when the first patients were being treated, we have the opportunity now to look at long-term outcomes of these patients. And so I will show you some new data that we are analyzing now in collaboration with Dr. Schuster and Luca Paruzzo in my lab, where we basically took the patient that were initially treated with what is now known as T-cell Genloocluso, is a 4-1BB co-stimulated CAR. And these 38 patients were treated in a single-center trial at the University of Pennsylvania by Dr. Schuster. And we have now an average median follow-up of 10 years. So we can look at the results at long term. And you can see if we take these patients with large B-cell lymphoma and follicular lymphoma, the progression-free survival is 23.7% at 10 years. But you may imagine now when we have a progression-free survival that spans over 10 years, some of these patients might be starting dying, for other causes because progression-free survival also include death as an event. And so we look at the disease-free survival. If you look at the disease-specific death or progression, you now see that about 40% of the patients at long-term don't have a relapse of their disease, which I think is pretty remarkable. What is the overall survival? Overall, the overall survival is 31% at 10 years in this population. But something that I think is very interesting, and of course is preliminary, is the fact that if we look at patients who are in prolonged complete response, so these are the patients who would never have a relapse for the 10 years of follow-up, and we compare their survival to the survival of an age and sex match population that is available, for example, through the NIH databases, you can see that the curves are pretty similar. So they're starting to get to similar levels, which means that potentially we are basically bringing patient, a subset of patient, we're bringing them back to the possibility of survival that is similar to a healthy or at least a controlled age match and sex match population, which I think it's really remarkable if we think about one-shot type of therapy. Okay, but again, as I mentioned, when we look at the progression-free survival, even in the best case scenario, like large B-cell lymphoma, we see that we're able to cure about a third of the patient. We're not really, and for this patient, this is of course is a remarkable impact, but obviously we want to do better. And the second, I think, important caveat is that we are still seeing severe toxicities. We do have patients that have grade 3 and 4 CRS. We do have patients that have severe neurotoxicity. And most importantly, we have a remarkable number of patients who would survive a decade without B-cell. And that's an issue, and we'll touch about that later. So again, my team is really interested in the resistant mechanism to CAR, the toxicity mechanism, and we think that only by understanding deeply what are the causes of relapse and toxicity, we can develop effective new approaches. And so I always try to update this slide to make sure that I include all the mechanism of relapse that have been described in this setting. And I always like to start with the so-called pre-infusion barriers. I always start from that because when we're talking about a therapy that is an autologous, patient-specific, highly expensive therapy that can only be given in tertiary centers, the fact that we're not able to deliver the therapy to a patient for multiple reasons should be considered per se a failure. And so we have access issues. We have done some work on minority health population access. We have 2 papers published on that. We have the issue that patient can progress while we're waiting for CAR T-cell manufacturing. We can have patients who do not respond to bridging therapies, and so they have high tumor burden and they cannot be treated, for example. There are also host factors that I think we are getting more and more interested in. We're actually organizing a scientific workshop at the American Society of Hematology in December to specifically focus on what are the host factors that can affect how CAR T-cells work. For example, we've done work on the microbiome, but we know that previous line of therapies, inflammation, immunorejection, and so on can also affect CAR T-cell therapy. But if we move to the sort of more biological and well-described causes of relapse, we certainly have the dysfunction of the CAR T-cell being a major player. This has been shown for a long time, in particular by Joe Fraietta, for example, and others, that CAR T-cells that are exhausted, that are terminally differentiated, they're not going to be able to do a good job in controlling the disease at long term. Likewise, the tumor itself can develop strategies to avoid recognition from the CAR T-cell or being resistant. And of course, antigen loss is now a well-established mechanism, loss of CD19, for example. We have done quite a bit of work on the role of apoptosis. There are mutations that have been associated with resistance. And so it's a characteristic of the tumor that make the tumor resistant. And today we'll talk to you a little bit about co-stimulation and optimal immune synapse. And lastly, the tumor microenvironment. So the tumor microenvironment is an environment that is metabolically toxic to the T cell. There is low glucose, low nutrients, low oxygen, acidity, and there are a lot of inhibitory factors. There are myeloid-derived suppressor cells, Tregs, and macrophages, and soluble factors, and many other reasons to block T cell function. So again, of course, we're not going to be able today to discuss all this mechanism, but I want to show you two stories on relapse and two stories, of course, next generation product. Let me start with the co-stimulation. So Alberto Carturan and Matthew Angelos in my lab have been looking into the role of co-stimulation as a critical factor that would drive CAR T cell function. So we went back to a CRISPR-Cas9 screening that was done in 2020, and that was the screening that led to the discovery of this apoptotic pathway as a cause of resistance to CAR. But we went back to that screening where we basically took leukemic cells. We use a Brunello CRISPR-Cas9 knockout library. So basically every cell would have a different knockout. And the question was, if we then add CAR19, which will be the gene losses that will be enriched and which will be the gene losses that will be depleted? And obviously, if you see that the gene loss is enriched, that means that that gene loss is beneficial to the tumor to make it resistant to CAR. And among the hits, one of the top ones was CD58, suggesting that CD58 deletion associates with CAR T cell resistance. So we are not the first one, of course, to mention and to study the axis of CD2 and CD58. There have been previous reports that suggest that this pathway is important for T cell therapies. But you will see we focus on understanding the mechanism and on a strategy to overcome the lack of this axis. And so CD58 is expressed in tumor cells and is expressed in stromal cells and naturally binds to CD2. And there are two main results of this interaction. First, the formation of a strong immune synapse. Second, the co-activation of the T cells through boosting of the TCR signaling. Unfortunately, in some cancer settings, and in particular in lymphoma, there are cases where CD58 is lost. Can be lost for many reasons, including direct mutation of CD58, which are well-known mutation in lymphoma. And of course, that can cause a defective synapse and reduce co-activation of our CAR T cell. So is this even meaningful in the clinical setting? So we went back to patients receiving CAR T cell, and we look at biopsies pre and post CAR T cell therapy. And it was very interesting to see that patients with low expression of CD58 at baseline, they had a shorter duration of response as compared with patients that had higher levels. And even more interestingly, I think, is that a subset of patients that you can see here, about a third of patients after treatment would show a decrease in the level of CD58 in the biopsies at relapse. So clearly indicating that there is a correlation between the level of CD58 and response to CAR T cell therapy. And so we knock out CD58 in a cell line. We try to model that in the lab. And we saw that, for example, already in vitro, when we do a killing experiment, a lymphoma cell line or a leukemia cell line that lacks CD58, this would be the light red or the light blue, you can see that they have resistance to CAR. So the level of cytotoxicity is lower as compared to their wild type counterparts. And interestingly, when we ask the question, is this because the synapse is defective? And we use the Lumix ZMOVI assay, you can see that the ability, which is the binding, the strength of the binding between the CAR and the tumor, was much lower when you go from wild type CD58 to light red is the knockout CD58. And so we went and moved on to the in vivo setting where we asked the question, well, if CD58 negative tumor cells have a survival advantage because they are resistant to CAR19, if we mix together CD58 positive and CD58 negative leukemic cells, we should see over time an increase of CD58 negative when treated with CAR19. And that's exactly what we saw. If you use untransduced T cell, they don't have any anti-tumor effect. You can see that there is no benefit of not having CD58. But when you have a selective expression of CAR19, well, now not having CD58 is actually beneficial, and CD58 negative cells will survive more than CD58 wild type. Of course, we kind of wanted to model the axis between interaction between CD2 and CD58 also on the T cell side. So in this experiment, instead of knocking out CD58 in the leukemic cells, we knocked out CD2 in the CAR T cell. And the results were pretty astonishing because you can see that this is a wild type CAR19 in dark blue, but you can see in light blue the CD2 knockout CAR19, they really have a markedly lower levels of tumor control, almost similar to untransduced T cell. And these, of course, reflected on a shorter overall survival of the CD2 knockout CAR19 as compared to the mock. So what's happening? We showed that the synapse is not optimal. What happened to the T cell? So we collected the T cells from the peripheral blood and we did single cell RNA sequencing and bulk RNA sequencing. And you can see that there were a lot of pathways. And of course, we have all the details in the paper that hopefully will be coming up soon. But you can see that in the knockout, there was enrichment of genes that have been associated with T cell dysfunction. While in the cells that were positive for CD2, you have enrichment of genes that are associated with T cell function. And so obviously, this is all interesting, but if we cannot try to find a solution for it, it becomes a problem. And so we hypothesized that we could potentially recapitulate the signaling of CD2 by creating a switch receptor that will provide internal CD2 signaling, but external, instead of having the CD2 extracellular domain, you have PD1. And so, of course, the CD2 extracellular domain is not really useful because there is no CD58. Instead, PD1, we know that can bind to PD-L1 and can transform a negative signal into a positive signal. Furthermore, we picked PD-L1 because in the immune synapse, PD-L1 is localized to the same region of the immune synapse as CD58. As you can see here, we can nicely express the switch receptor together with the CAR on the surface. And when we did the experiment, we took a CD58 knockout, PD-L1 positive NAM6, and we compare wild-type CAR19 that we know is suboptimal to the switch receptor CAR19. You can see that the switch receptor was doing much, much better than the wild-type CAR19 that we know is already pretty effective. So again, the idea is that in the absence of CD58, having the switch receptor will benefit the patient greatly. So this was story number one, so the role of co-stimulation. I now want to focus on another story that deals with host factors and how can they affect the CAR T cell functionality. And so there is a lot of interest in the role of the gut microbiome, for example. We know that in studies of the checkpoint inhibitor, the gut microbiome has a very strong influence on how the patient with solid cancer at checkpoint respond to checkpoint therapy. Furthermore, we know that antibiotic use can affect checkpoint inhibitor efficacy in solid cancer. In 2021, we published a paper that was the first paper to show that the microbiome actually also has an effect on CAR T cell therapy. And so there are many ways to study the microbiome, but we decided to start with among the many approaches to see what's the effect of diet on CAR T cell therapy. And Shen Liu and Punith Guruprasad presented this work at the ASH plenary in 2024, and this is a collaboration with Dr. Mayan Levy, who used to be at Penn and now is at the Arc Institute in San Francisco. And the question that we started was, again, thinking about the microbiome, but really opening it to what is the role of metabolites and nutrients in affecting CAR T cell responses. And so we try to recapitulate the human diet, as you can see in this schema, by giving controlled diet, which is mostly carbohydrate, high fibers. You can see in green there are starch fibers, high protein in white. You can see Western diet, which is basically a high fat diet plus cholesterol, high fat. And then we also use ketogenic diet, which is mostly a high fat and high protein type of diet. And the reason why we also included ketogenic diet is because my collaborator, Dr. Mayan Levy, has shown that ketogenic diet is beneficial in slowing down the growth of solid cancer. And there is evidence that it can potentially be a boost to the immune system. So we use an immunocompetent model for this goal. And we use a lymphoma A20 cell line and a murine CAR19. And we gave the diet before tumor implantation and throughout the experiment. And the results were very interesting because you can see that in multiple repeated experiments, the best diet in terms of tumor control was ketogenic diet. So what was the mechanism beside the ketogenic diet efficacy? Well, it's interesting because we did metabolomics analysis in the serum of mice receiving ketogenic diet versus control diet. And the top enriched metabolite, you can see is the fold change, is the highest fold change, was beta hydroxybutyrate. So this is a ketone body that is known to be enriched when you do a ketogenic diet. And so the question was, well, instead of doing all the combination of the complicated ketogenic diet, which is, personally, I think it's very hard to comply to, but also in a patient population would be hard to implement, can we perhaps only give one single metabolite and recapitulate the effect of ketogenic diet? Well, that was exactly what we saw in the animal model. We compared ketogenic diet to BHB, and we saw that basically we got the same anti-tumor effect. And when we look at the T cell function, you can see that the number of T cells that are highly active, IL-2 positive, interferon gamma positive, was higher inside the tumor, to similar level in BHB supplemented CAR and ketogenic diet supplemented CAR. And so, of course, the next step was to move from an immunocompetent model to a humanized model. So we use immunodeficient mice, NSG mice. We gave a human lymphoma cell line, OCLY18, which is notoriously resistant to CAR19. And then we gave beta-hydroxybutyrate, or BHB, which is the abbreviation, or vehicle, and then gave CAR19. And the results were pretty remarkable because control untransduced T cell, of course, don't have an anti-tumor effect. BHB alone with controlled T cell doesn't really do much. You can see that there are no complete responses. CAR19 obviously does something, and we use a very low dose, so we didn't expect complete responses. But when we did the combination of CAR19 plus BHB, you can see that 6 out of 7 mice were in complete response, only by changing one single metabolite. And so, of course, the next level, again, getting closer to patients, is the healthy volunteer cohorts. And so we purchased a ketone body supplement that is called Ketone IQ. We gave it to healthy volunteers at time 0. And then after 90 minutes, we checked the function of the T cell. Again, with the idea that BHB might be boosting the T cell function. It was very interesting. So what we saw is that supplementation of BHB increases the oxygen consumption by T cell, and these T cells are able to generate more energy. And in more mechanistic studies that I don't have time to show today, we demonstrated that human CAR T cells are able to pick up BHB faster than glucose, and the BHB is able to boost oxidative phosphorylation, generating a lot of energy for the T cell that then can proliferate more and can have a better anti-tumor effect. We think that that's the main mechanism is actually not through the microbiome, but through the energy production of the T cell. Of course, ultimately, we want to test this in humans. And so we have now a clinical trial at Penn that is led by Dr. Elise Chong. In this trial, we are enrolling patients with commercial CAR T cells. We're giving them beta-hydroxybutyrate after lymphodepletion. Patient will continue to get beta-hydroxybutyrate for 1 month. And of course, we're going to look at the metabolites in the serum, the expansion of the CAR T cell, the microbiome, and so on. Okay, so this was the second story, how we can metabolically modulate the function of T cell by changing diet. The third story deals with the fact that we have been very, very successful over the last decade to develop CAR T cell for B-cell malignancies. We have now approval for acute lymphoblastic leukemia, chronic lymphocytic leukemia, non-Hodgkin lymphoma, multiple myeloma, but that's it. We don't have CAR for other hematological indications. We don't have CAR for solid cancer. So as a hematologist, I became very interested in developing a CAR product for T-cell lymphoma. So why T-cell lymphoma? Well, T-cell lymphoma is a disease that it's really hard to treat, and the overall survival is extremely dismal. And so we generated a new product in collaboration with viTToria Biotherapeutics that targets CD5. CD5 is highly expressed in T-cell lymphoma. Most patients express CD5. The caveat, though, is that CD5 is also expressed in normal T cell. And so we had to knock out CD5 from the T cell in order to avoid the so-called fratricide. And so we did that with a sort of a next generation manufacturing process that is 5 days. So the first day we do the electroporation of the knockout machinery. Then we activate the T cell in the afternoon. The next day we will put the lentivirus, and on day 5 we will harvest and freeze the cells. And I think what is very interesting about this product that is now tested in the clinic, and I will show you some initial results, is the fact that at the end of manufacturing, which again is only 5 days, you have a product which is 100% of the cells, they are CD5 knockout. So there was no CD5 at all. But only 30% of the cells have a CAR. So we call this as a dual population product, where you have the CAR, which you can see here, CAR positive, CD5 negative, and CD5 negative, CAR negative. And the interesting aspect of this is that the CD5 negative, CAR negative, they are autologous T cell. So they have their own T cell receptor. And the reason why we really like this population is because we think that these T cells can actually provide protection in case of T cell aplasia, in terms of recognition of CD5 positive cells, normal T cells in the body. We did a lot of work in the lab to show that this system works, and we saw very nice preclinical activity in mice. We have now opened a trial that is led by Stefan Barta, who is the T-cell lymphoma lead at Penn. And this trial includes patients with CD5 positive T-cell lymphoma that are relapse refractory after at least 1 line of chemotherapy. There is standard lymphodepletion that can be either Flu/Cy or bendamustine. And then we're testing different doses of CD5 knockout CAR5. I would like to point out that the dose that we're currently using it's only 3 million total CAR-positive cells. So I think it's one of the lowest doses that has ever been used in CAR T-cell therapy. So the first question, are these T-cells even working and able to expand? And these are, again, preliminary data. We will show the full data set for the first 6 patients at the American Society of Hematology in December. I'm showing you 3 patients right now. You can see that even infusing 3 or 10 million cells, we get a very nice peak expansion on day 14 that is pretty much in line or even higher than what we see in commercial CAR-19 products. Most importantly, or at least equally importantly, we are starting to see that over time, starting at week 2, we see a reconstitution of CD5 negative T cell. So the hypothesis is that we are actually infusing not only the anti-tumor portion of the product, the CAR positive, but we are probably also infusing a boost of normal T cell that can actually provide protection. And this is shown even more clearly here when if you look at the relative contribution of the different subset, 5 positive, CAR positive, and all the potential combination, you can see that the CD5 positive CAR negative cells, so the normal T cell, disappear when the CAR T cell in yellow start to grow. But at the same time, when the CAR T cell are starting to grow, you see that the CD5 negative T cell without the CAR are repopulating the host, which is in line with our initial hypothesis that we are providing also T cells that can provide immunity and repopulate the host. And so obviously I cannot show the full clinical efficacy information, but I want to show one representative case. This is a patient with a peripheral T-cell lymphoma with extensive disease. You can see the disease in the neck. You can see the disease here in the groin. The patient was infused 3 million CAR-positive cells, and you can see the results at day 28. There is no longer tumor. And the exciting news is that this patient is still in remission over 6 months after 3 million CAR T cells. Okay, so that was story number 3, expanding CAR T cell therapy to other indication. And now the last part of my talk is going to be focused on the effect of CAR T cell in terms of toxicity. So we know that the interaction between CAR T cell and cancer cell can lead to a plethora of consequences. One of them, of course, is the killing of the cancer cell, which is exactly what we want. But at the same time, this interaction drives cytokine release from the T cell that in return will activate myeloid cells, endothelial cells, and other all sorts of cells that cause generalized inflammation. So the most classic toxicities that have been described after CAR T cell are cytokine release syndrome, neurotoxicity, but we're now realizing that cytopenias are also a big component of these therapies, mostly due to inflammation and also lymphodepletion. And there is also a contribution, and that's what I want to talk to you about today, of the fact that targeting CD19 or targeting BCMA would deplete B cells or plasma cells, leading to B-cell aplasia or plasma cell aplasia, with the consequent low levels of immunoglobulins and a remarkable risk of infection. For example, when we look at, this is one of the many papers that we can find, when we look at the infection risk after CAR T cell, is very high. It is actually the top cause for non-relapse mortality. So patients are dying not of their disease, but they're dying for infections. And we did a study where we looked, for example, at the titers of anti-COVID vaccine response after CAR. And you can see that many patients don't have a response after CAR. And you can see that also here. Many patients don't have a response even several months after therapy. And so what can we do? Well, maybe we should change our perspective. So the perspective of killing all the B cell, of course, has been quite good in terms of clinical results, but have also been leading to the aplasia of normal B cell. And so we want to change that paradigm to a more precise targeting of the bad guys of the neoplastic B cell. And so Ivan Cohen in the lab is leading this project. And the idea is to, instead of targeting CD19, can we develop a therapy that can target the B cell receptor, which is specific for the cancer cell? Well, obviously, we cannot make a CAR product for every single patient. So we cannot make a CAR against the idiotype of every single patient. But luckily, we realized that the BIN work, and this is in collaboration with Kostas Stamatopoulos, with Paolo Ghia, who are BCR experts. There have been studies that have shown that there are certain classes of immunoglobulins of B cell receptor. For example, the variable heavy chain 434. So this is a specific gene that leads to the heavy chain, when there is the recombination, is highly enriched in lymphoma. I can show you here some data. If you look at the 434 frequency in a normal B cell, extremely low. Look what happened when you look at B cell malignancies. You have some of the lymphoma subset, for example, the central nervous system or lymphoma of the eye that have 60 to 35%. But even the most aggressive lymphoma, which is the ABC, large B cell lymphoma, 30% of them have 434 BCR. Why is that? Well, the reason is that, as you can see here, this specific chain is naturally self-reactive. So these 434 BCR are able to bind to N-acetylactosamine, for example, expressed on CD45, leading to clustering and stimulation of the BCR. So it makes sense that they're enriched in lymphoma. And by the way, they're also enriched, for example, in lupus, in other autoimmune diseases. And so the idea was to develop a CAR product that is specific for the 434 B cell receptor. And so when we did that, we realized, though, that there is a specific distance between the CAR on top and the tumor on the bottom that ensures optimal CAR function. When you have a BCR, well, a BCR is much bigger than CD19. It's more than 3 times the size of CD19. And so if you develop a CAR sort of with the classic structure, it's not going to be optimal because, as you can see, the distance is much longer. And so we developed a new concept where, for targeting the BCR, we reduced the size of the hinge from CD8 to 2 different forms. One was the short IgG4, and the other one was only 5 amino acid, the G4S. And so the idea is that now we can have a shorter hinge that would ensure the right spacing between the tumor and the T cell. To make a long story short, when we tested in mice this product, the old hinge, this is the long hinge, didn't lead to any anti-tumor effect. You can see in green, this is the CAR against 434, in gray, CAR19. But when we tried the other hinges, so the short IgG4 and the short G4S, we now saw a very nice anti-tumor effect similar to CAR19. And so, of course, this is something that we are very interested in continuing to develop. We are developing it also for autoimmune diseases where maybe there is even a more dire need into try to avoid B-cell aplasia, even a short term. Okay, so I will wrap it up now, and I want to just summarize what I've been discussing with you today. Well, I show you that in a subset of patients with lymphoma and potentially also other diseases, not having CD58 would lead to resistance to CAR19. And while we try several strategies, including, for example, putting CD2 as a co-stimulation in the CAR, that really didn't work. The approach that was most successful was the development of a switch receptor that would bind to PD-1, PD-L1 on one side, and would have CD2 on the inside. Of course, now the next step would see, well, is this switch receptor working also in other models, and we're doing that. And then what will going to be the clinical efficacy of this approach? In the second project, I show you how ketogenic diet enhances CAR T cell function, and we think this is mediated through enhanced metabolism, in particular OXPHOS. We're seeing now effect also in solid cancer models. We think that in solid cancer, there is also a direct effect on the cancer cell. So a lot to discover there. But we also discovered that you can use potentially metabolites, and we studied with beta-hydroxybutyrate, to manipulate the way T cells work. And again, by giving beta-hydroxybutyrate, we saw that we can recapitulate the effect of ketogenic diet. And so we had increased Krebs cycle and OXPHOS in our CAR T cell. I mean, I'm sure that there are additional mechanisms. I mentioned the microbiome, the epigenetic effect of BHP, but we think that the major one is on the modulation of the OXPHOS. And lastly, we're doing now a pilot clinical trial that has already enrolled 10 patients that is evaluating the supplementation of BHP to boost CAR T cell. And I then show you a completely new product that is targeting CD5 and is targeting CD5 with a CD5 knockout. We have a trial ongoing. The results are very promising, will be presented at ASH. I would mention, though, that the CD5 knockout, we have discovered that is also a strategy to boost T cell function, regardless of the fratricide. So in our Science Immunology paper that we published last year, we showed that also CAR19 or CAR against mesothelin, if they are knocked out for CD5, they will have a better anti-tumor effect. So this is more like a platform that we can apply to multiple T cell therapies. And lastly, I show you how we can start thinking about changing the paradigm of B cell targeting to try to be more specific, to try to avoid B cell aplasia, to be more specific to the BCR that is sort of the clonal barcode that is unique for cancer cells compared to normal B cells. And as I mentioned, we are also evaluating these concepts in the setting of autoimmune diseases. Of course, all of this is possible by our team at the University of Pennsylvania and our collaborators. I want to stress a big thank to my lab, and many of the members who worked at this project were already acknowledged, and many others are listed here. Of course, the Center for Cell Immunotherapy, Karjun leading it, and all the members of his lab. I want to thank Joe Fraietta, is a very close collaborator. The lymphoma team, we also work a lot with the Center for Cellular Therapy and Transplant and Myeloma. The work with autoimmunity is done with the Colton Center, and all our collaborators in academia, in the company, and of course, the patients and their families that allow us to translate quickly our findings to treatments. And of course, a big thank to many of our funders. It's been a pleasure to working with these foundations and companies to advance our concepts. And again, thank to all of you for your attention today. And I think we have 15 minutes for questions that I'm happy to take. Thank you.
Perfect. All right. Well, thank you very much, Marco, for your informative presentation. We will now go ahead and move into the live Q&A portion of the webinar. So if you happen to have a question that you would like to ask, please go ahead and do so now. Just click on the Ask a Question box located on the far left of your screen. Okay, let's go ahead and get started here. All right, the first question that we have here says, how does loss of CD58 impair CAR T cell activity, and how might CD2-based signaling overcome this?
Yeah, so CD2, really the main ligand for CD2 is CD58. So not having CD58 in the tumor leads to the lack of engagement of CD2. And so from one side, we show that the immune synapse formation is defective without the binding between CD2 and CD58. From the other side, and we have, of course, more work on that on the paper, we show that the signaling upon antigen encounter is diminished if you don't have also CD58 in the cancer cell. So I would say it's a two-pronged effect, is the suboptimal synapse formation and the lack of co-stimulation when the CAR engages the target. So we think these are the two main mechanisms that we see.
Perfect. Okay. The next one that we have here says, how does CD5 knockout CAR T therapy address fratricide and immune recovery in T-cell lymphoma?
Yeah, so again, one of the challenges when you develop CAR T cell for T cell malignancies is the fact that most of the targets that you are going after are also expressed by normal T cell. CD7, CD5, CD2, even CD30, I would argue. And so you need to find a way to avoid that the CAR T cell will kill each other's and also will kill the normal T cells in the body of the patient. And so by knocking out CD5 in the CAR T cell, you basically remove the target from the CAR T cell and they're not going to recognize each other. And so that's what we developed to avoid fratricide. But then the other concept is that we were able to develop a product that has two populations within the same product. And so the knockout of CD5 in normal T cell would allow us to infuse a subset of T cell that are autologous. They're not recognized by the CAR, and so they have a survival advantage as compared to the normal T cell that have CD5. So we think that they can provide some, at least temporary, anti-infective role upon infusion.
Okay, wonderful. The next one that we have here says, which resistance mechanisms are most actionable for future CAR T engineering in hematologic cancers?
Well, this is, of course, is a very broad question, right? That it would take a long time to uh, uh, to to address. But suffices to say that I think that it would be multiple approaches, right? So we have patients, for example, who relapse without CD19. And so for those patients, obviously targeting multiple antigens would be beneficial. There are patients who have a loss of CD58. And so, for example, our switch receptor would be able to address that. There are patients that have very poorly functional T cells. And so any strategy, for example, the CD5 knockout, BHP supplementation, and other strategies that other groups have published might be beneficial for those patients. So I think we're going to get to a situation where we're going to look at the pre-treatment biopsy, pre-treatment T cell quality, and the next step would be, okay, can we generate a combination of treatments that specifically addresses those deficits that they have and those characteristics? I think it's a little bit early because we're not very good at predicting at this point, but I think we'll get there.
Perfect. Okay. So we will go ahead and wrap up with this final question that we have here. And this one says, what clinical data support metabolic interventions such as ketogenic diets or beta hydroxybutyrate in CAR T therapy?
Yeah, thank you for that question. I think it's a very important question. So we're now the paper is hopefully will be published at some point, and there are more information there. But the key concept is that when we look at patient cohorts, we did see a correlation between the BHP levels that patient have for multiple reasons, like the diet or whatever is their metabolic makeup, and the expansion of the T cell. So while we don't really have population of patients that are already in ketogenic diet, so we cannot really tell. That's why we're doing the clinical trial. I think there are some correlative data that would suggest that that the levels of BHB in the serum might correlate with CAR T cell expansion. So that's really what we have so far. But obviously, the clinical trial will give a more definitive answer.
Perfect. Okay, wonderful. Well, thank you again, Dr. Ruella, for your time today and for your very important research. Before we go today, I would like to thank the audience for joining us today and for their very interesting questions. Questions that we did not have time for and those submitted during the on-demand period will be addressed by the speaker via the contact info that you provided at the time of registration. Now, as a reminder, this webinar can be viewed on demand for 1 year until October 15th, 2026. LabRoots will go ahead and alert you via email when it's available for replay. And we encourage you to share that email with your colleagues who maybe missed today's live event. All right. Thank you very much, everyone. Until next time. Goodbye.
Thank you. Bye.